Caries Classification and Management, ICDAS and ICCMS narrated explanation. Let's walk through Caries Classification and Management step by step using ICDAS and ICCMS and understand not just what they are, but why they exist and how we actually use them clinically, why ICDAS and ICCMS exist. We begin with ICDAS, which stands for the International Caries Detection and Assessment System. ICDAS is an evidence-based, standardized system designed to detect and record dental caries in a consistent way across different clinicians, settings, and countries. Unlike older indices such as DMFT or DMFs, which only record cavitated lesions, ICDAS records caries based on lesion severity and depth, even when there is no cavitation. This means ICDAS includes subclinical lesions, initial non-cavitated enamel lesions. Because of this, ICDAS shifts dentistry away from early drilling and toward prevention and remineralization, especially for early-stage disease. Now, ICDAS tells us what we see, but it does not tell us what to do. That is where ICCMS comes in. ICCMS, the International Caries Classification and Management System, is a clinical decision-making framework built on ICDAS findings. It integrates diagnoses, caries risk assessment, preventive strategies, operative treatment, only when truly indicated. The primary philosophy of ICCMS is simple but critical: preserve tooth structure and restore conservatively. So remember this principle clearly. ICDAS detects. ICCMS decides. Requirements for applying ICDAS correctly. ICDAS is only accurate if it is applied properly. First, tooth surfaces must be clean and dry. Plaque must be removed before examination. This is done using a toothbrush or a polishing cup. After cleaning, the tooth must be air-dried for at least 5 seconds. This is essential because early enamel caries may not be visible on a wet surface. When enamel pores are filled with water, the classic white spot lesion disappears. Next, examination is performed using a ball-ended explorer, not a sharp one. The recommended probe is the WHO CPI PSR probe, which has a 0.5 millimeters ball tip. The explorer is used only tactfully, never forcefully. Its purpose is to remove plaque and debris, assess surface contour, confirm cavitation if present. Sharp explorers must not be used because they can damage enamel, create cavitation. Promotor regium, progressium, ICDAS caries categories. ICDAS classifies caries into 2 main groups. First, coronal caries, which include pit and fissure caries on occlusal surfaces. Smooth surface caries, involving mesial, distal, buccal, or lingual surfaces. Caries adjacent to restorations or sealants, abbreviated as CARS, also known as recurrent or secondary caries. Second, root caries, which are assessed separately for each root surface. ICDAS codes for coronal caries. Now let us go through the ICDAS codes from 0 to 6. Code 0, sound tooth surface. ICCMS classification, sound. This means there is no evidence of caries. For pits and fissure surfaces, there is no caries, no change in enamel translucency after 5 seconds of drying. For smooth surfaces, the criteria are the same. 4 CARS. This means the surface adjacent to the restoration or sealant is sound. Any marginal defect is less than 0.5 millimeters, with no signs of caries. Importantly, the following conditions are still considered sound: enamel hypoplasia, fluorosis attrition, abrasion or erosion, extrinsic or intrinsic stains, such as coffee staining. Code 1, first visual change in enamel ICCMS, initial stage caries. The defining feature of Code 1 is that the lesion is visible only after drying. For pit and fissure surfaces, when dry, a white or brown opacity is seen, limited to the fissure. When wet, there is no visible caries. For smooth surfaces, when dry, opacity is visible from the buccal or lingual view. When viewed occlusally, nothing is seen. 4 CARS. After drying, opacity or discoloration is seen adjacent to the restoration. There is no gap between the restoration and tooth. Code 2, distinct visual change in enamel ICCMS. Initial stage caries. Here, the lesion is visible both when wet and when dry. For pit and fissure surfaces, white or brown, opacity is present. The discoloration is wider than the natural fissure. For smooth surfaces, lesion is visible from buccal or lingual views, whether wet or dry. When viewed occlusally, a shadow confined to enamel may be seen near the marginal ridge. For Caries, opacity or discoloration is visible adjacent to the restoration. There is no marginal gap. The lesion appears more obvious than in Code 1. Code 3. Localized enamel breakdown with no visible dent in ICCMS. Moderate stage caries. This is the first code where cavitation is present. However, the cavitation is confined to enamel. Dentin is not visible. For pit and fissure surfaces, enamel breakdown is present. Cavitation can be confirmed using a ball-ended probe. For smooth surfaces, cavitation is visible from buccal or lingual views, often proximal, and may be missed when the tooth is wet. For Caries, cavitation at the restoration margin is less than 0.5 millimeters. Caries opacity is present. The key distinction here is important. Code 0 Caries may have a defect, but no caries discoloration. Code 3 Caries has both cavitation and caries opacity. Code 4, underlying dark shadow from dentin ICCMS, moderate stage caries. In Code 4, dentin is affected, but not exposed. The key feature is a gray, blue, or brown shadow from discolored dentin, seen through intact or slightly broken enamel. For both pit and fissure and smooth surfaces, the shadow is visible through enamel. It is often easier to see when the tooth is wet. For Caries, Code 2 features are present, plus a dentinal shadow. At this stage, only the shadow of dentin is seen, not the dentin itself. Code 5, distinct cavity with visible dentin ICCMS. Extensive caries. Here, dentin is exposed. For pit and fissure and smooth surfaces, there is cavitation in opaque or discolored enamel. Exposed dentin is clearly visible. A dentinal shadow may be seen at cavity margins. The deep pulpal dentin must not be probed to avoid pushing bacteria deeper. For Caries, a marginal gap greater than 0.5 millimeters is present, confirmed using a 0.5 millimeters ball-ended probe. Exposed dentin is visible. Code 6. Extensive distinct cavity with visible dentin ICCMS. Extensive caries. This represents severe destruction. The cavity is deep and wide, involves 50% or more of the tooth surface. Exposed dentin is visible on the walls, the base of the cavity. There is a high risk of pulp involvement. This applies to pit and fissure caries, smooth surface caries, Caries, root caries, Each root surface is scored independently. Root surfaces are excluded if there is no recession and the root is not visible. The surface is covered with calculus scored after removal. Root Caries codes. Code 0. Sound root surface. No discoloration or contour loss. Non-carious defects, such as abrasion or erosion, may be present. Code 1, initial root caries. Clearly demarcated brown or black discoloration. No cavitation! Loss of contour less than 0.5 millimeters! Code 2, cavitated root caries. Discoloration with cavitation. Loss of contour. 0.5 millimeters or greater. Understanding how to properly classify and manage cavities is key to providing the best care for our patients. We'll be focusing on the International Caries Classification and Management System, or ICCMS, which gives us a clear, evidence-based framework to work with. So break down the 3 main stages of caries lesions according to ICCMS. It's simpler than you might think. We have initial stage lesions, moderate stage lesions, and extensive stage lesions. An initial stage lesion is the very first sign of demineralizing. Think of those white spot lesions on a smooth surface or a light brown discoloration in a fissure. The key here is that the surface is still intact. There's no cavity yet. This is our chance to intervene with known invasive treatments like fluoride varnish and oral hygiene instruction. Next up, we have moderate stage lesions. This is where things get a bit more serious. At this stage, we start to see localized breakdown of the enamel. You might see a microcavity or a visible dark shadow from dentin underneath the enamel. The lesion has progressed beyond the initial demineralization but hasn't yet reached the point of a large open cavity. Management here often involves what we call minimally invasive care, like sealing the lesion or a small, conservative restoration. Finally, we have extensive stage lesions. This is what most people picture when they think of a cavity. There's a distinct, wide open cavity, and the dentin is clearly visible and exposed. These lesions are deep and require more involved restorative treatment to remove the diseased tissue and rebuild the tooth structure. The goal is to stop the progression, restore function, and prevent further damage or pain for the patient. Now, how do we actually describe these lesions consistently? That's where the International Caries Detection and Assessment System, or ICDAS, comes in. ICDAS is a visual scoring system that ranges from code 0, which is a sound tooth surface, all the way up to code 6, which is an extensive, distinct cavity with visible dentin covering more than half the surface. For example, an ICDAS code 1 or 2 would fall into that initial lesion stage. We talked about a change in enamel that you can see when the tooth is dry. Codes 3 and 4 represent the moderate stage, showing early signs of breakdown. And codes 5 and 6 signify an extensive lesion. Using ICDAS helps standardize how we talk about caries, whether it's with colleagues or for patient records. The ICCMS framework also helps us stage both coronal caries, which is on the crown of the tooth, and root caries. The principles are similar, but the appearance can differ. Root caries tends to be softer and spreads more widely since cementum is less mineralized than enamel. We still classify it as initial, moderate, or extensive based on the texture and cavitation. An initial root lesion might be a discolored area without a surface defect, while an extensive one would be a clear cavity on the root surface. Radiographs are another crucial tool in our diagnostic arsenal, especially for lesions between the teeth that we can't see directly. The ICCMS integrates radiographic findings into its staging. We use a simple classification, RAW, for lesions in the outer enamel, RB4, lesions reaching the dent-enamel junction or into the outer third of the dentin, and RC4 lesions in the middle to inner third of the dentin. Combining the visual ICDAS score with the radiographic raw RB, or RC depth, gives us a comprehensive picture of the lesion's severity, guiding our treatment decisions. So let's put it all together. How do we manage these different stages? For initial lesions, think prevention and This means fluoride treatments, sealants for pits and fissures, and patient education on diet and brushing. For moderate lesions, it's about minimally invasive dentistry. We might do a preventive resin restoration or a small filling, preserving as much healthy tooth structure as possible. For extensive lesions, we move to traditional restorative care. This could be a larger filling, a crown, or in severe cases, root canal therapy if the pulp is involved. The beauty of the ICCMS is that it links detection and staging directly to a management plan, making our clinical decisions logical and patient. That's a wrap on our overview of caries staging with ICCMS. It is a powerful system that helps us move from simply drilling and filling to a more personalized and preventive approach to caries management. I hope this breakdown was helpful for you. If you have any questions, drop them in the comments below. Don't forget to like this video and subscribe for more content to help you excel in your dental career. Thanks for watching, and I'll see you in the next one.